Hello, I'm Claire Cameron and I'm a consultant in health protection at Public Health Scotland, presenting on behalf of myself and Laura MacDonald and the team. You've heard about the lab setup, you've heard details about Mendivar, and now I'm going to go on to describe how we apply all this in health protection. First of all, a word about the role of Public Health Scotland. We coordinate enhanced surveillance of all meningococcal cases in Scotland, working closely with the reference lab and reporting boards. We also field health protection inquiries for individual clinical inquiries, outbreak and incident investigations, supporting boards, and contribute to education and guidance. First of all, a word about the background epidemiology of meningococcal disease in Scotland. The graphs here on the left, they show the cumulative number of meningococcal cases each year from 2017. The graph on the right, that shows the number of meningococcal cases by serogroup from 1999, when we introduced Men-C vaccine, right the way through to the current day, looking at impact of Men-B and Men-ACWY vaccines also. The total number of cases fluctuates each year. The downward trend, though, is very evident, as well as the impact of the pandemic. So the first example I wanted to give about the use of Mendivar is in outbreaks and incidents. This is an example of a cluster across two health board areas. There were cases in a university town and then more cases across the wider communities. And this was in the context of increased incidence of invasive meningococcal disease across Scotland. So there was quite a bit of anxiety and media coverage. In this instance, whole genome sequencing was able to rule out a link between the university cases. But had that not been the case, Mendivar would have been absolutely crucial in informing the vaccine strategy for this situation, which particularly for the university could have been at scale. Nevertheless, it was still really important to use Mendivar in this situation to be able to inform our individual health protection measures to give that reassurance, working with the UK guidance. The second example of applying Mendivar is in individual clinical inquiries. Now, the Men-B vaccine was introduced in 2015, and we know that despite really high vaccine effectiveness, it cannot be expected to cover all serogroup B strains. So we can have cases in vaccinated infants who are perceived to be vaccine failures. And the Mendivar scheme is really useful to be able to understand that profile. This is very important information for parents and clinicians trying to make sense of individual situations. And it's also more widely important for vaccine confidence, because we know that this is a more complex situation. And the final example I want to give is really that of the individual cases, but writ large over the whole country and over time. This graph here shows the total number of Men-B cases across Scotland from 2010. And then the line at the bottom here, this shows the number of cases who've been vaccinated. It's really important to look at the impact of vaccination against disease. And although we know there's very high vaccine effectiveness, it's still very important to characterise these breakthrough cases, whether they're partially or fully vaccinated. And Mendivar has helped us to do that and to look also at the strain distribution. So we do all this work in partnership with colleagues at Glasgow and in Oxford. Thank you.